India reports nearly 1 lakh cases of blood cancer every year. And this is a number, I think, which reminds us to stay informed, spread awareness, and also understand what are the advances that are being made in its treatment. So welcome to this podcast. I'm RJ Deepthi from Radio Mirchi, and I have with me Dr. Hari Menon. He is the professor and HOD of Medical Oncology and Hematology Department, St. John's Medical College and Hospital, Bengaluru. Welcome to the show, Doctor.
Yeah.
I want to start off with asking you, what is hemato-oncology and what is its core?
So when we talk about oncology as such, as a field, it's a field where we are dealing with cancers, or when we want to say in a more professional manner, malignancies. So when we're talking about cancers can involve any part of the body, and when we're talking about cancers involving the blood and related organs and what we call as the hematopoietic system, which includes the immune system also. That area of cancer is what we broadly classify as the field of hemato-oncology. So all cancers, all associated types which might be linked to cancers or which might evolve into cancers all come under the field of hemato-oncology. So we talk about the lymphatic system, we talk about the bone marrow and its system, we talk about the immune system, the lymph nodes. All malignancies can arise from all these things, and that broadly encompasses that field in terms of hemato-oncology. So now that is, earlier it used to be under the field of oncology. Now because of the advances in science, there are so many other things that have developed, so it has become a focused area. We like to call that hemato-oncology as the field of malignant hematology, yeah, where we are dealing with malignancies associated with the blood and blood-related organs. Yeah.
Got it. Now, you were talking about the lymphatic system. What is lymphoma and what is leukemia for a novice like me?
So, when you're talking about leukemias, immediately it strikes you for a person that it is blood cancer. What one does not understand is lymphomas are also a type of cancer related to the blood. But we try to segregate or separate these two into two different entities. When we talk about leukemias, it means the type of malignancies that arise from different components in the blood, and there are different types of cells in the blood, from each of which can be a cause for a leukemia because of various transformations, mutations, genetic changes that happens. So broadly, those components of the blood which become malignant, we call them as leukemias. And those which are associated with the lymph nodes, yeah, and the immune system. And even within those, there are different forms of cells which occupy the lymph nodes, which are basically associated with our immune system, the ability to fight infections. And they are also actually populated by cells called lymphocytes. And their various precursor forms, what we call as earlier form, which there is a process of them evolving from one cell to the other. So any of these cells can be a reason for developing lymphomas, and those types of malignancies we broadly like to call them as lymphomas. So for a layman, one might say, okay, lymphomas are those which are arising from lymph nodes, which are where there are tons of them all there. Practically, you put a finger, you have a lymph node over there. But sometimes when they become malignant, it emerges as a diagnosis of a lymphoma. And even in lymphomas, there are, just like leukemias, there are so many different forms of leukemias. There are so many different forms of lymphomas that we could. So that's how the field evolves, and then there are so many subspecialties in that. So those things are what we need to. So broadly, we can say blood cancer, truly a blood cancer is a leukemia.
Okay.
And those cancers arising from the lymph nodes and the immune system are generally referred to as lymphomas. That's just for a layman, but it may not be the exact kind of definition one would like to look at for a person who really wants to look at exact definitions, but for a layman, that's good enough.
Yeah, I think this podcast is the objective is to spread awareness.
Yeah.
So I don't know anything about blood apart from RBC, WBC,
Yeah.
and plasma.
Yeah.
So the
Yeah.
WBC, the immune system.
So that
Is
is what one feels that, okay, many people, a layman would say, okay, the increase in the WBC counts, that the white blood cell counts is what is associated with leukemias. And in fact, the term leukemia is white. Luke means white.
Oh.
So everybody likes to say, say that, okay, leukemia means a malignancy arising from the white blood cells.
Okay.
But it's not necessary. You can get leukemias from any of the components of the white blood. But majority of the leukemias are arising from the white blood cells. So that's why you get leukemia. Why was the term leukemia come into picture? It is basically from the from Latin term leuc, which means white. Yeah.
Interesting.
Yeah.
I want to now go into the treatment of it. Can
Yeah.
you explain BMT for us?
So it's a very, very, very complex area, and generally, if you want to look at trying to talk about leukemias and their treatment, it has evolved significantly over the period of time. So, in leukemias, what do we have? We have cells that are having uncontrolled proliferation, they are malignant, and they are triggered by various causes, which is beyond the ability to discuss on this fora, but there is going to be there are various factors that will result in the formation of leukemia, and those are primarily because of acquisitions of certain mutations, which is ongoing in the body. Even as I speak, there are various mutations that are happening in the body at every point of time, and it is being removed also by a very wakeful immune system. So that is why that's an incredible aspect of the human body. You generate abnormal cells and they identify them as abnormal and they clear it. So, but it is when the immune system tends to be a little weak, or the reparative mechanisms that are existing in the body that gets damaged or get blunted, then when you have manifestations. And those can be secondary to various factors. One, it could be that you're prone to developing, other can be environmental stimulus, it could be sometimes associated with your lifestyle, sometimes it can be due to exposure to chemicals. So there are various reasons, but one cannot point out that this could be the reason for leukemia, except for a few specific conditions. Most of the time, leukemias are spontaneous events which happen, and anybody right from the day that you're born to the day that you die can develop leukemias. But the kind of leukemias can vary between what you see in pediatric population to what we see in the middle-aged or in the adolescents to what we see in the elderly population. But on a broad basis, you can say leukemias are diseases that are in the extremes of age. In the pediatric population, you have a higher incidence. In fact, it's the second most common form of cancers, and mainly lymphatic leukemias, as we call in the pediatric population. Whereas in adult patients, you have what are known as myeloid leukemias, which are a different set of leukemias. And even in those, there are various subsets that you see. And that holds true even for lymphomas, for example. You have specific kind of lymphomas that have a propensity in the younger population versus some of them. But overall, when you see hematological malignancies or malignancies involving the blood and blood-forming organs, are probably predominantly a disease of the aging population. As you grow older, your chances of developing leukemias are much higher. So you were talking about the treatment. So the treatment of leukemias is always about what merits the situation. Most of the time, it is involving using chemotherapy drugs, that is chemical agents which we target, and they have various ways of mechanism, and at the end of the day, you're trying to eradicate the tumor cells, which are probably more sensitive to chemotherapy than the normal cells. So when we give treatment, some of the normal cells also get affected, and that's why you get side effects of the treatment. Because the malignant cells are more prone to or more susceptible to the chemotherapeutic drugs that we use, they tend to get destroyed. So the cornerstone of many of the treatments for leukemia is chemotherapy. And then that has evolved into and that has evolved to other drugs and other forms of treatment where we look at using targeted therapies. In fact, one of the biggest paradigm shift in the management came with the treatment of a condition known as chronic myeloid leukemia, and it in fact came back as the first time in cancer you have a magic bullet, for example, to treat cancers, where you give one drug and you are able to treat it. And that came on the cover of Times magazine also, I think sometime way back in the early 2000s. Yeah. So the magic bullet for treatment of cancers, but those are not something which is like for all comers, like, you know. So there are certain specific entities where you have a specific target which is a driver for that particular cancer. You block that target with some medications and you end up with better control of the disease. So this understanding has grown to spread to other forms of leukemias also, and blood cancers, where you are able to target those lesions. And that is where the era of targeted therapy has come into play. And now we also know that some of, but not all leukemias, and many of the lymphomas, not all lymphomas again, are amenable to immune-mediated responses, because many of the cancer cells that we know can evade the immune system, and that's why they are able to have a survival advantage in the body and they can proliferate. So this understanding of evasion of the immune system and how it happens has triggered a new area of cancer treatment itself, which is known as immunotherapy. And in fact, the 1917 Nobel Prize was awarded to the scientists because they identified this particular pathway, and it has spawned a whole area of immunotherapy, not only in hematological malignancies but also in solid tumors. So the understanding that how we can make the immune system recognize the cancer cells by manipulating the way that the cancer cells behave, or by blocking certain receptors in the cancer cells and making them exposed to the immune system, is one of the biggest breakthroughs that has happened in the management of cancer. So you have to treat leukemias based on what merits the situation, what is the kind of leukemia. So it is very, it is not one entity, isn't it? It has several different soils, which requires different distinct forms of treatment that needs to be looked into for treating these conditions. So this is something that has to be addressed. So today when I am sitting in my clinic, people come, so can't we give immunotherapy also for the patient? I will say that not all leukemias are amenable to immunotherapies, but it is important to identify what leukemias and what lymphomas are amenable and use it in a judicious fashion to be able to get the best possible results when you treat the condition.
What about bone marrow transplant?
So again, so as I said, bone marrow transplant has been an entity which has been there in the field of as old as probably in the last 4 decades or so. It has been there, but it has evolved the way it is used. So what is bone marrow transplant? There are 2 different forms of bone marrow transplant. One is not truly a bone marrow transplant. It is just a way of assisting giving high doses of chemotherapy, which is known as an autologous stem cell transplant. That is only a way of delivering high doses of chemotherapy, because the principle of autologous stem cell transplant lies in the fact that those tumors are responsive to chemotherapy, especially when you talk about lymphomas. It is not used so much in leukemias, but in lymphomas. Those tumors are sensitive to chemotherapy, but may not be sensitive to chemotherapy in the doses that we use in conventional setting. But they may be amenable to higher doses of chemotherapy. But when we give higher doses of chemotherapy, we are ending up with toxicity which cannot be, and from which the bone marrow cannot recover. So what we do is, if we identify, for example, a lymphoma which is sensitive to chemotherapy, but is not completely, eradicated or removed by the conventional doses, we think about giving higher doses of chemotherapy, actually harvest the stem cells which are supposed to regenerate the bone marrow, take it and keep it, actually literally keep it in the refrigerator through a mechanism, what is known as pheresis. We do it. We identify those stem cells, keep it in the refrigerator, or what we call as cryopreserve it in them. And then we administer those high doses of chemotherapy. The premise is that when you give higher doses, the cells that are not responsive to conventional doses may get destroyed by higher doses. But when we do that, we are destroying the bone marrow also. So we actually replant the bone marrow with the stem cells that have not been exposed to the treatment. exposed to the chemotherapy, and they rejuvenate the bone marrow or regenerate the bone marrow, and the patient is able to recover. So it doing a harvest does two things. One, you deliver high doses of chemotherapy and you rescue the stem cells. So that is an autologous stem cell transplant. But when we do an allogenic stem cell transplant, although the only similarity in that terminology is transplant, they are completely different things. So when we do allogenic stem cell transplant, we are actually using the body's immune system to actually fight the cancer cells. So this is actually truly a bone marrow transplant, or truly a transplant, and we call this an allogenic stem cell transplant. Why we call it allogenic? Because the cells are not that of the patient. The cells are donated by a donor, cells which could be one of his siblings, or it could be even sometimes a parent, where we call it as a half-match transplant or half matching. You need to have a match. There are some things at the levels of at the chromosomal level, at the genetic level. We need to have a match with them when we do the transplants in these patients. And there are ways, and so we use those stem cells to actually, because as I told you in the beginning of this discussion, that the immune system is primarily responsible for eradicating and keep the cancers under check, and that a normal individual does not develop cancers. So you are giving an immunocompetent cell from a donor into the recipient, and you are destroying their entire immune system by giving chemotherapy first, and then you're replanting the bone marrow stem cells which we have got from the donor, and we are replacing the entire bone marrow with a foreign cell. So when we do that, they are immunocompetent cells, and these immunocompetent cells are able to recognize the tumor and kill the tumor. So allogenic stem cell transplant is something that we do for hematological malignancies. We don't do it for solid tumors because it doesn't work in solid tumors, but we do it in hematological malignancies because the immunocompetent cells are able to destroy what we call as the cells that we get from the donor is called the graft. It's called the graft. And there is something called the graft versus host disease, or graft versus, and this graft versus host disease is also called a graft versus tumor effect or graft versus leukemia effect. So when these graft cells come, they are actually live medicines actually that you're giving. They go and destroy the tumor cells that are present in the system, and that way the patient gets a new immune system and a new graft and a new marrow actually by virtue, because they go and populate the marrow and they become what we call as a donor marrow. Yeah. So, but there are also problems that develop because of that, because the donor cells are immunocompetent and the recipient cells are actually getting the donor cells and the immune system, and the immune system will start considering the donor cells, the recipient's body as foreign. Yeah. So they're saying, oh, this is not my body and I need to destroy it. So it starts going and destroying. So that's when you have the problems that are related with the allogenic stem cell transplant, what we call as graft versus host disease. So at one point, you might be able to eradicate the disease, but you end up with a problem known as a graft versus host disease, which can be even more challenging to treat than anything. But the success of a transplant becomes how well you can balance the graft versus host disease with the graft versus tumor effect. So without graft versus host disease, you cannot control the disease. But if it goes above a certain point of control, then it will destroy the recipient and the patient. It will result in mortality of the patient. So it's a double-edged sword doing a transplant, but that is one of the modalities of treating, and it is an important aspect of treating hematological malignancies. And we adopt to allogenic stem cell transplant in situations where we cannot get the disease under control with conventional techniques. Yeah.
While all of that was scary to know that even the treatments can backfire sometimes.
Yeah, of course, yes.
Give us some hopeful message.
Oh, there are so many things that, the management of all these problems have, if you talked to me 30 years ago, it was a challenge. It was a much bigger challenge. It's less of a challenge. Now we have such wonderful drugs where we can manage the immune system. There are immune manipulations that you can do to reduce these things. So it's like a give and take kind of a situation. It is actually increasing its utility in terms of treating these malignancies. And it has to be exercised, but with very judiciously in terms of, you must not understand that it should not be like a ditch effort that, okay, there is the only hope is to do a transplant. You're good. So you must also look into the fact that whether is the patient going to benefit with that, and there are a lot of criteria which goes into play for us to decide whether that is going to happen. So everybody will think, oh, we can do an allogenic stem cell transplant, but we have to be judicious. You know, always at the back of my mind, we said, are we going to end up with problems with the patient? And is the patient being able to take the transplant effectively? So the other thing that, since we are on the subject of transplants, the next thing that has come is again a variety of autologous stem cell transplant, which I talked to you before, where we use the patient's own cells, and that is what is known as chimeric antigen receptor T cells, or what we popularly known as CAR T cell therapies that has come into play recently. It's also a form of transplant, but it is an autologous transplant. Here, we are actually manipulating the tumor cells or the T lymphocytes, which is supposed to be the ones that is going to actually are the surveillance mechanisms in the body, to actually identify the target tumor cells by actually artificially manipulating them in the laboratory to express certain receptors which are there present on the tumor also. So it is able to identify, so it will home in on those receptors and elicit an immune response which will result in a tumor kill. So it's a form of targeted therapy. Those are the advancement that has been happened. But it also comes with its own challenges, but not so much as the challenges that we face with graft-versus disease. So every modality of treatment has its advantages, and it is going to be useful if we apply those in an appropriate setting. That is what is most important. And that's where you need to have, even I would say you need to have restraint in terms of implementing treatment. Just because you have the ability to do a transplant should not be the reason why you will do the transplant for the patient. Yeah.
Thank you, doctor.
Yeah.
I think this chat reminds us how information is useful, and being judicious with all the available treatments is also helpful and much needed right now. Thank you, doctor.
Thank you.
I'm RJ Deepthi. Until we meet next time, take care of yourself and your loved ones.
Thank you.